I don't know. Let me get to some actual logistic questions that I have for fear of not getting to them, and they're really about ultrasound guided intervention. And then I want to share with you a study, and if I can do it correctly, if it doesn't get jerky and you can't see it. But the questions I have about ultrasound guided injections.
Yeah.
I have two patients, of a son, and then ultimately I onboarded his mother with the exact same complaints, and they have both lit up insertions of their posterior tibialis tendon at their arch. They were previously just, injected for plantar fasciitis and all that kind of stuff. And I'm seeing that area that, the supposedly this knot of Henry thing where the FDL and the FHL do their little cradling of each other there and
Yeah.
moves around. And I have one guy in my area that does my guided injections and does so, I'm hoping, with a little bit of his own critical assessment, but his imaging skills are entry level. And
Yeah.
and so I am concerned. I should just ask you the question. If I deliver a boatload of cortisone, can I just assume that it's going to spread out and cover both pathologies? Um, if I can just tell the guy, do it to this spot here. I don't know the answer to that question. And then the other thing is, I'm told that because posterior tib plays such a role in weight bearing, that it has the same characteristics and concerns that we have in the Achilles tendon for rupture. And so can you share with me the answer to both those questions? This sounds like we're at a press conference and I only get two questions, but let's start off with those.
Uh, Injecting tibialis posterior. We see quite a lot of it. We see a lot of ruptures. We don't necessarily have proved link between the two, but there is certainly a lot of concern. And these days, it's very rare for anyone, certainly within the NHS, to inject around steroid around tibialis posterior. It's become much less fashionable. It was something that we would do quite a lot of, and I've certainly done it in the past. And it's effective in calming it down. Usually, the view nowadays is there's a process in process, and the steroid just causes a hiatus to that process. So it's a band-aid over a progressive disease, which is there's normally some sort of progressive process when you see that. So we tend to take a slightly more conservative view and don't really put a load of steroid in there, even if it might be it's quite inflamed. But I think it's an effective treatment. It just comes at a cost, and that cost is in risk of accelerating the journey towards rupture.
Okay, so I will buy that as an anatomically relevant comment on where we're talking about specifically, and maybe alter it in saying either prolotherapy or PRP or any of these biologics that they can put in there. What about using just an anesthetic for diagnostic accuracy of this being the principal problem? Is that ever something that is
Yes,
reasonable?
that tends to be more likely what I would do. I tend to, if I'm asked to inject it and the patient is adamant they want an injection, sometimes I will use something like a lidocaine marcaine mix. So that's a long and short acting anesthetic, and I will do what I loosely think of as a sort of stripping type procedure, a sort of expanding type procedure, where I just will inject a reasonable volume, not a huge volume, in along the sheath around the tendon. Now, the local anesthetics have a slight cytotoxic effect on tissue, but nothing like to the degree that steroids do it, I think, if you're going to make a comparison. And so I see that as a much lesser evil. It gives the patient some relief. it possibly has some therapeutic value. I do it when I have to. It's not something I'm doing very often. And the guys in private practice, and certainly around the world, you hear them talking, there are alternatives. There are things like PRP and the rest of it. And you can imagine that they may have a role in it. People have tried some of the hyaluronic acid. I've not seen any evidence to say it works, but that never stopped anybody doing anything.
Yeah, I think sometimes just intervening in that area is appropriate. When both of these people cannot tolerate any pressure on it, meaning orthotics just actually sets them down, and neither one of them can stand longer than 2 hours, and they both work at the family owns a local restaurant, and so they're on their feet doing a lot of prep, and they have to take turns. They can only stand for about 2 hours before they have to get off their feet, and it's just I'm beside myself. I try to do all the tools that we can do, and we can try to do strengthening, and we can try to do all that, but when you're so far behind this 8-ball, I'm in a quandary as to how to give these people a break. And so at the very least, assuring myself that I do have the zone that is causing the problem. How long would your long-acting anesthetic take effect? Are we talking 4 hours? Or are we talking, you said lidocaine and what other one?
Marcaine. So Marcaine is supposed to last about 8 hours. I think patients get relief for much longer than that, because it settles it down. It's put some fluid in. It fills it up with fluid. So you get some relief. I think there was a study once that showed 3 weeks benefit from local anesthetic.
Wow. I just need you right next to me here. So move here so that we can just have you doing this. It is so mind blowing that there is a therapist who's even having the gall here in the United States to tell people, I want you to go to this specific doctor who's doing guided injections, and the repercussions of even me doing that, I'm watching play out. But that's the process here in the United States. It's just, all right, that's all valuable to me. Now let me back up to the concept of simply saying, how do I break this down? I went to a hand conference once where the hand orthopedic surgeon was presenting to what he thought to be 250 family practice doctors. My brother was a family practice doctor. He invited me, and while there, the hand doctor took a question from one of the family doctors that said, we don't actually know where that tendon is, they said, that you're asking us to inject. How do we know exactly where it is? And this was his response. As long as you don't put the needle through to the wood of the counter their hand is on, and you use 3 cc's of something, it's going to ultimately get there. And I remember thinking to myself, holy moly, did he just tell this family practice doctor that providing he doesn't go through the entire wrist and he delivers this boatload of stuff, he's going to ultimately get there? And so in my mind, I've gone, how do I juxtapose that to these guided injection tutorials that are showing a person getting just between the interface of the subacromial subdeltoid bursa? How do I justify the one comment to the other? Will it get through to the bursa if you just happen to put in 3 cc's? Now I'll be quiet.
Yeah, well, you must have seen Pulp Fiction.
I did. Why am I dead?
You don't remember when he gives them the big heart injection? I like it. Yeah, you can stick, if you're going to inject sort of 120, 3 cc's, 3 mil of depomedrone. If you put it into a bottom, it'll get everywhere.
When you say bottom, do you mean butt?
Stick it into their bottom.
Okay. Okay. It will get to piriformis. It'll get to sciatic. It'll get to all the gemellis.
Finger joints. It'll do the whole work. It
So
is. It
you're
is
saying if
standard.
it's like a dose pack that a person takes.
Yeah, in rheumatology, it's an oft-used technique when you're looking, instead of one or two joints, you've got multiple. People with multiple joint arthritis, they will put a bolus of depomedrone, 120 milligrams, which is your normal 3 cc dose, and they'll put it in your bottom, and it will affect all the joints. It's a big enough dose.
Okay.
If you think that's about, if you had something like PMR, polymyalgia rheumatica, depending on your body weight, your general practice doctor, your family doctor would start you off on a dose of maybe 30 to 60 milligrams. So this is double the first day's dose, and you just stick it straight in the bottom in a crystalline form, which slows the release slightly, and that is a accepted practice. If you are looking at a single joint or a single tendon, you don't really want to wash that much around the body. Only a relatively small amount gets to each individual target. So, which is the advantage of doing a guided or unguided local injection. But you get washout. I had a case. I'm trying to put a couple of videos together of a case of stenosing extensor pollicis brevis. The small bit of the dequervens. Yeah, I had a patient there where it was stenosing, so that the tendon was actually being restricted by a tightening of the band there, and I put an injection in, but it was so tight. Even though I had the needle in the right place, the steroid was actually going into the sheath beside it, so it wasn't actually going into the sheath. But she did very well, and all shrunk down very nicely. That was right next to it, but when you put it roughly into the area, it's going to have that effect. With a subacromial bursa injection, they don't show hugely different outcomes, whether it's done guided and unguided. And so there's a lot of talk here, particularly where money's an issue, and should it be guided or should it be unguided? And guided is seen as more expensive. We get better results, but we don't necessarily get better results in every case. And I think subacromial bursa is a good example, where if you've got a reasonable dose of steroid, you're going to get an effect, and a local effect, even if you're not actually in the target. We find that effect is less, anecdotally, when we're looking at joints. And all the studies that have looked at the small joints and smaller structures have shown better results that I've seen from guided injections. But the guys who are doing them unguided, who are missing most of the time, in reality, they're still getting reasonable results because they're close.
And by close, you're basically inferring that there is a traveling out of whatever the medication is, and it's not restricted enough by the interface to wherever they're trying to get that it. I mean, I would like to think that if 100% is delivered to the actual tissue at fault, there's going to be more rapid lasting effect. But what you are saying is that if it is delivered near there, it is just a day or two difference, or are we talking an hour or two difference, or it's just hard to say?
You don't always get the benefit from a steroid injection for anything up to 2 weeks. We regularly see patients either not getting benefit or getting extra pain for anything up to a week after a steroid injection.
Even if you're confident you had it in the field, exactly.
Well, we're doing guided injections on good kit, and we've been doing them for years. And I remember I was sort of helping out in a study, just an audit at one place I worked a long time ago, where the patient got a form and told us how they felt. And for the first week, each day, and a lot of them were worse in that first week. And we thought it wasn't really working, or there were percentages that were just failing. But I happened to meet and do injections on a number of those patients for other parts of their body. And I remember asking them, why are you back? Why are you having your left shoulder injected? We injected the right and it didn't work. It says so on this bit of paper you sent us back after a week. And it goes quite regular occurrence. And they would say, oh, but it was fantastic at 2 weeks.
Interesting.
Yeah.
Why do we not then put in some form of analgesic along with that, so that you say to yourself, or so the patient goes, this guy's a rock star, only because it takes the pain away?
We do that. We put in, when I inject steroid, I would normally put in, depending on the joint, a local anesthetic with it, and depending on the target. If I'm going into a big joint, I'll often use one of the lower density, lower concentration Marcaines, but into the small joints and non-weight bearing joints and around the soft tissues, I tend to just use lidocaine. It's nice and quick. They feel the benefits straight away.
Yeah. Move here. So the other, I guess what I'm hearing you say is more than just whatever that anesthetic is as you get the needle down. And I think the last conversation I had with you is you rarely will even do preparatory injections with you never do them. What about anterior hip?
Wherever you go, I usually have local anesthetic in the syringe. So I put the needle into the target and I inject the local anesthetic and the steroid in. It's uncomfortable for a few moments, but no more than that.
Interesting.
And a lot of my patients have had procedures where they've done lots of that, and they've asked me to do it, and I've just said no. And I've said, and at the end of it, you'll say, that was fine. And they do say, that was fine.
Okay.
I
will tell you, universally, as I'm watching some of these online educational people who are doing guided injections, universally they'll be doing this little thing initially, and then they'll be doing the other one. And I guess my concern is, you're saying, though, in your vial, you've shaken up both the anesthetic and the
I don't shake it up. I just draw up some local anesthetic, and I put in I put in local anesthetic, 2 or 3 mils if I'm doing a subacromial bursa, and depomedrone, 20 or 40 milligrams, which is another half mil or full mil, and it just goes into the same syringe, and then the syringe goes to the target, and I inject it.
All right. I know this is probably elementary to you, but it is intriguing to me. And if I'm ultimately going to be, I don't know whether or not I'll have any takers on actually watching the sucker go down, because if what you're telling me is that deliver a payload, buddy, and it'll ultimately get there, then I have to ask myself, how do I convince a person who's been doing this in a small town situation on an island that they really need to have me helping them do it, other than their fear of hitting something like in a hip or something like that?
They work better. They work better, and they are, and you can use a lower dose, which is better for the patient, better for the tissue. Did I start? Is that you screen sharing, or am I?
No, I'm gonna quickly screen share with you. Were you gonna show me an injection, bud?
No, I just did. Screen changed, and I wasn't sure.
Oh, okay.
I thought I'd pressed something.
I'm wanting to know if what you have on the screen looks like a blurry Greg Fritz effort at my initial cine loop. All right. Yep. What I want to show you again, and again, this is the vulnerability thing we talked about. This is going to be a short axis scan of the humerus. I'm going to be trying to follow the long head of the biceps up and over through the groove. I ultimately want you to realize that this was one of those occasions where I found a large black mass, or should I say a hypoechoic area in the bursa, and it was uniquely located next to or near the subscapularis tendon. So yet I did not see much coming around. So I just want to have your input onto this, and let me see if I can even get you to see it. If I do this, I don't know, are you seeing any movement, or is So you are seeing me kind of go in and out through attempting to optimize. I'm now at the top and I'm oblique on the long head. Periodically, I will do it correctly, and I'll have some effort to orient the what do you call it, the elevation, whatever. Are you seeing it?
Now I'm going to write some numbers on here, and I'll give you scores.
Good. That will really reduce my fear, John. But what I want to have you realize that this is in essence a loop that I start usually at the pec major insertion. I go right above it. I try to go up, catching it through the groove, and then as I go over the top of the humerus, I try to go a little bit more to an internal rotation, trying to get that slice thickness in line with the tendon. So what I'm going to do next now is I'm going to show you, hopefully if I can go here. Are you seeing that oh, how come yours is not? Oh, there we go. You're a little behind me. Now we're long axis on the subscapularis insertion. You know what? It warms my heart that I'm seeing your head go up and down. That means at least you understand the echo texture of what I had. So I'm going to actually hit start here, and hopefully you'll start to see that as I was scanning to see what the footprint looked like, this little black area comes over the subscapularis, and I'm intrigued because there does not seem to be a communicating component across to the other part of the rotator cuff. And I think that there's even, let me see if I can go, I go long axis even further. I'm gonna stop here. I'm almost done being vulnerable with you, buddy. Here's I think one more view of this same thing. I am now long axis and I'm taking on subscap. No, I'm short axis. This is short axis on subscap, and I bring it over to being long axis on the long head. And you probably could tell that by the fibers of the deltoid being in long axis too. So we're going from the footprint in short axis, and it has this teardrop shape there. And the echo texture on the bottom brings me over just for a short wink at the long head as it goes down the humerus. So far, I'm trying to at least get you oriented to what I do here in my effort at scan. Can you tell me what that is? Is that a separate bursa from the subacromial subdeltoid? Now I'll listen to you.
That is the subcoracoid bursa, or that's what I would describe it as. They are not necessarily separate, but that fluid, if you're scanning the patient when they are sitting down,
yes,
then that is the dependent part of the bursa, even if they are connected. And sometimes the subacromial is continuous with the subdeltoid, and sometimes they are separate. So the fluid can be in the down at the bottom of the subcoracoid bursa because that's fluid from the whole area, or it's just fluid from the subdeltoid subcoracoid element.
I'm hearing what you're saying, and for some reason, I don't know why it's still looping on the shared component. This was supposed to be linked.
Hang on.
Are you hearing me at all now? Okay.
Wait 1 second. I'll be back.
Okay.
It just got very slow, and sometimes that's someone running something in the house, like that disturbs the router. But it seems to be fine. We got to stand back.
This is the last one I'm going to share with you. This is what I was attempting to do for an interval view of the supraspinatus. You can see the long head blink in there periodically, and you'll ultimately be able to see the subscapularis, and I believe at the edge of the screen you'll be able to see that bursal area. So is that still what you would call then, as you take a look at the 3-dimension? This is a subcoracoid bursa.
There's another bursa. There's a bursa that or an outpouching of the joint that can appear high up in that area, but But in this case, I think it is almost certainly the subcoracoid bursa that is mildly distended.
As you're looking at the short axis cut right there of the long head and the view of the supraspinatus, the function loss in this individual and the fact that she was able to forward flex and even abduct her shoulder, I'm seeing evidence of what I would view as in the space of the supraspinatus tendon, it looks quite homogeneous. It does not look as fibril as I would expect. But can a person draw some conclusions without, I don't know where you would go testing wise to say, is this just fibrotic material that has assumed the space, or if this is a contractile component that truly does represent a supraspinatus, an integrous supraspinatus. Does that make sense to you? She did not seem to present frozen shoulder like, but she had a classic pain response that I would have expected to see a supraspinatus deficiency. But
yeah, I can't. It's difficult to go from that. I'm not seeing a tear in that tendon.
Okay, and that's valuable to me. I'm almost done asking you questions on my studies, but
That's right.
If a person goes to the let me see what I can throw over here. If a person let me show you one more thing, since I'm being vulnerable with you. I think there's such a delay that it places into my buffering this whole movement, and I don't know whether or not very soon here I'm having actually go on the iPad the long axis view of the rotator cuff, so that you'll be able to see me at least make an effort of sweeping from the long head of the biceps across to the infraspinatus here in just a second. But while we're waiting to catch up with the buffering, how much value do you place in a short axis slice of the muscle bellies as you determine whether or not this has been a long-term supraspinatus full retraction? Does that make sense? Is there fatty infiltration that you can ultimately say has a signature that you could say this has been a 3-year or 5-year retraction, because that's turned into to Kobe beef or whatever else?
I wouldn't pay good money for Kobe beef if it looked like that. Let me have a look. Which day was it? Should I share? Can I share with you?
Yes. Let me turn off this share, or maybe let's see. Can you turn it off, because I've given you control to share?
Okay, let me share.
Or maybe I have to stop share.
Yeah,
I'll
hit
stop share. Now you can give me the share.
Yeah. Okay, let's see if that works. Now, have you got what of my screen?
Yep. I see the file system.
Have a look. Now, I saw just in the last couple of days, so you have to bear with me, a lovely case, and I trying desperately to remember which day it is. It was of a suprascapular nerve entrapment. That's the one. Let's see if we can share that.
Crud! I never scanned that. You're going to have to help me learn to do that, because that means you caught it on a thorough scan.
I caught it. I almost the tail though of this is I almost missed it. Absolutely normal scan, normal scan. And the guy had pain, and he had pain in the back of the shoulder. And you're thinking, oh, is it coming from his neck? And I just happened to, and I missed it where it's most obvious. So when you come to see the picture that shows it properly, I didn't see that when I scanned through. I saw the joint, and I'll stop it when it is. I just happened to. I've got into the habit of just having a quick look in the suprascapular fossa.
Now you're saying you are long axis on the infraspinatus, and then you slide it up Or a suprascapular is above the supraspinatus. We're at the top of the clavicle.
So
scapula.
I look proximal to the acromion. So I just sweep proximal to the acromion. After I've looked at maybe at the AC joint, I just come back, either in long section, but usually in short section, just sweep down through the muscle belly of supraspinatus.
Yes.
Yeah. And this is what I saw. Just this bit here, just that picture there. And it just didn't look. Can you see where my arrow is?
Yes.
Yeah. So that's it. And it just caught my eye. That's darker than it should be.
Yeah.
So that's all. And I went through it and I thought, and I couldn't really see it. This is on a probe place. I do a list where they haven't got a proper MSK probe, so I'm just using a vascular probe. So the picture quality is not amazing. And then I go back and I look at my normal view for looking at the back of the joint, and this is what I'd taken. Yeah. So the posterior view of the joint.
Yes.
And then I actually did my job properly, and I went sideways. Yeah.
Yes. Oh my goodness! So that's just on the other side of the glenoid.
Yeah.
And it
extends this one extends all the way up under the supraspinatus, and then all the way back in the infraspinatus. And I very nearly watched it. But the point of showing you this is not that. It's as I go through it, and you're going to come, and I'm going to come up through here. Wait a second. So this is the infraspinatus fossa, yeah?
Yes.
Yeah, look at the quality of the muscle. It's not really, and I'm going to go a little bit further through, and hopefully we will get, I think and do you see this muscle just at the side?
Yes.
That's teres minor. You see the
texture? Yes, it's hypertrophied to at least assist in external rotation. Oh, no?
No, that's normal muscle texture. This is not normal muscle.
So that's fibrotic.
Now this is this is suprascapular nerve impingement, presumably second to the thing, but that's the texture. And hopefully, so if I wind back through slowly for you,
goodness,
and this is why we do it. There, do you see that texture?
Yes.
Absence of muscle
texture, yes.
And this is what you see. There, you see that's the infraspinatus, short axis of infraspinatus.
Yes. Unbelievable, John. This has to be a case, buddy. This does so many things because it shows the location of that, what I call a posterior window, where you're looking for labrum, where you're looking for the humerus, the glenoid, and then we see it off to the side, and now you basically slid more medial, and you're looking at the infraspinatus.
Yeah.
Wow.
And you go, you have to look back. So, and this is what I tell my students. I say, when you're looking at that posterior view, you're not scanning the back of the humerus. You're looking at the back of the humerus for osteophytes, but you scan the glenoid. You scan the glenoid like you scan any joint line. You just scan around it. You just have as far as you can go inferiorly, as far as you can go superiorly, and you just have a gentle whiz through, and you're looking at that, and you look at the fossa behind there, because that's where you see the cysts. And nowadays I'm a little bit more precious, and I just have a quick look, because I've been caught out a couple of times. I just have this quick look behind the acromion at the top. And it only takes a second. But
this is why I am so fortunate to have access to this discussion, John. This is fabulous, and you made the best out of driving a stick shift, because that's a vascular probe that you were using, and you were actually pulling off an MSK study.
Yeah, but that's just this is no worse than the MSK scanners were 10 years ago. So
yeah, that's probably true. That above that, the very top of that is deltoid.
Yeah. Yes, probably.
I always get confused as to whether or not we're looking at the traps or that over supraspinatus it's deltoid below supraspinatus. Because of the spine of the scapula, it becomes lats or traps or something like that.
Yeah, I think of it as deltoid all the way around, really. The deltoid hangs off front,
Yeah.
back, and side. So usually you're looking through deltoid.
Now, I want to keep going with your studies because they're far more interesting to me. But I want to ask you a question. If
Yeah.
you ever see what looks like bony erosions in, I've seen several fractured humeral heads. If you ever see that kind of crevasse and it's proximal to the footprint of the supraspinatus, like it's actually into the articular cartilage, the round component of the humerus. If you can find that in an arc scan, is that how confident can I be that that's worth commenting on?
If it's down along, there are two places where you see that incidentally as a normal finding, and that's along the articular margin of the subscapularis, and you see a lot of irregularity along the along the articular margin over the inferior portions of infraspinatus. So you often see those sorts of changes. Certainly cortical irregularity, a bit of almost like a ditch running along there, and you don't want to be caught out by that, because that is just a normal finding, particularly in an older person.
Boy, I would just love to have you sideline that particular thing you're talking about into a series of just still shots for me, to be able to say, hey, Greg, this is normal, this is normal, this is normal. This is what we see when there is an actual compromise in the humerus that indicates a fracture. Because I remember when I was first playing with scanning on my kids, and I would come across to what I think to be a nutrient foramen in the bone, and I would go right through it. And if you held your probe in the right spot, it looked as though there was a fracture, but move it just a millimeter or two, and it comes back together, like where a vessel goes into the bone, like there's this little pock or whatever. I just, when I'm imaging a person who does have articular cartilage, or we get that black line fairly clear, and then I see this what looks like a crevice in the bone itself, and it is in certain areas, there has to be anatomically a regions that you can say, this is a throwaway, that is what happens in some people, but you never see that in this location. I guess that's what and now I'll listen to what you're saying.
Let me just see if I got if any pictures come up straight away. For some reason the hard drive on this thing, my Mac doesn't do a good job of cataloging my external hard drive, so I do have issues with the whole certainly live searching fracture.
Do you know how valuable this is to me, John? This stuff is valuable enough to me that if it means that I make a contribution to put this at a fast pace with a quality device, I want to be that person.
yeah. If I could find a way, it's only just recently, after our last effort of trying to show you stuff and show some of my colleagues stuff, that I realized there is a problem with the way it's searching. Fracture. No, for some reason the shoulder ones are not coming up, and it might be that I've mislabeled them. So I think we won't worry about too much about that. I will try and look up some fracture pictures for next time.
That would be great, only because, again, I know that I have. I mean, when you see an entire bony piece that slipped off of the humerus, that's one thing. But to identify. Let me see if I can just quickly share this with you. I was able to pull up the one of the things, and let me pull this down, see whether I can actually, come on. I know this is, I'm getting to the end of my time with you. Hopefully I can, there, here. Let me see if I can even play this where you can see it. It doesn't work, and I don't want to waste your time on it. So I'll unshare, and I'm going to get back to just.
Let's see if I can. Can I?
Yeah.
I'm just going to share with you again. Just see what we got here. I'll just see speculatively. Let's just have a look. Am I sharing? Oh, right.
Yep.
Hang on.
Nope, I have it, but I don't have the actual image. I have the file system.
Let's try again. Yeah, that's screen desktop too. Okay. Let's see what comes up when I do this. Right. Okay, we can't fix for quality.
But that was next to the groove of the long head.
That I think is a fracture there in the tuberosity. It's not a great example. These are just straight off a search of the hard drive. Let's see what else I've got. Fractured coracoid. Now that was an interesting one, but I will shoulder great fracture minimal displacement. Yeah, this should be more like it. Yeah. See that?
Yes, I do.
Yeah, that's an ambiguous one. That's the sort of thing where I would be 50-50 because of where it is, but you can see some of it is more obviously fractured.
Yeah. When you see the discrepancy in the line of the periosteum, or that cortical area, what else could it be? Does the body just all of a sudden lay down this step off, or
there is because of the anatomy.
Yes.
Because there is if there is a step down, and that step is vertical, and for some reason, or you get a bit osteophyte or changes in the bone, they can sit like that. If you think that picture, if you imagine a spur, the shape of a spur in the heel, it has that almost like the anvil type effect on a cumulonimbus sort of thing.
Yes.
And you get that in very small, and you have your various slice thickness issues, and you get this appearance there, and you don't see. It's like I once missed a subtle compression fracture of the radial head because the step down was so clear cut, that change of direction from bright, and then you got bright there, and you've got to see the defect. But because it has this rounded shape, and you don't see the bit going down, so that's why you can get these steps, and that's why you have to be a little bit careful about that. And also, a nutrient vessel could be coming out there.
Yes. However, as you're going through there, I see what my mind wants to see as debris or callus formation, or something around that makes me go, that just has too much metabolic waste, or at least some parts were not reabsorbed.
Yes, yeah, that's exactly what it is. It's a fracture. What have we got here? I'll just switch to that. Possible undisplaced fracture callus. Yeah, let's look. What we got there? Yeah, and here that it is from a car accident, and this is not in the. This is on the sort of past the insertion of the supraspinatus. This is here, and this is where they've taken a big smash this way, and they probably dented the bone here. but it is only probably, because you do get odd things like that. But there's too much as I'm scanning round. It's too linear and too much there for me to think it's just a malformation of the bone outside of the joint, which you can get.
You're able to follow the fault in the bone in far enough that you say this can't be something that was just a spur or a osteophyte or something like that.
Yeah. So this is where I think and because of where it is, I think it's just, and they complain that they've got sort of high-ish arc impingement, and I'm thinking actually it's fine up to there relatively. They've also had some tendon issue, but as they really take that the acromion, the greater tuberosity under the acromion, that's going to cause a little bit of friction. There were some bursal issues with it, and we discussed treatment, but I was fairly I was very much of a view that fracture malunion, OA shoulder post fracture malunion. I think this is probably a little bit more spectacular than you're interested in seeing. Yeah, this is just a deformed thing there. Let's see. It
was a growth on a fracture that we're
just a deformed head. There wasn't really a lot to see there. I'm just trying to see whether there was an interesting one I had recently. Let's see where it is. Fracture shoulder. I thought I just showed fractured. No, I recently had a case of fractured coracoid. Yeah, this was again a very subtle one. In a difficult shoulder. With a ruptured long head of biceps, and I was trying to make sense of. I was trying to scan the subscapularis, and the coracoid just looked wrong. And as I scanned down,
it looked wrong because you were not expecting the bone echo to be in that location.
Yes, okay, and the first thing I thought was this some sort of weird calcific deposit,
angulation,
or literally it crossed my mind that it could be some sort of avulsion, but it was just the wrong shape. And so I just scanned up and down it, and it comes to an end like that in one direction, and like that in another. And I suddenly realized that they'd actually 18 months previously, when they'd fallen down the stairs and not gone to A&E, that actually snapped their whole.
What about coracoid. That? So of the actual coracoid, did they snap the distal 2 centimeters or centimeter or?
Probably 2 centimeters.
Now, along with that, is there humeral coracoacromial, the trapezoid ligament up to the clavicle, or are we too far? Are we too far back on the coracoid to have lost its clavicle?
There are some of the ligaments coming off it there. So you've got the coracoacromial, and that's possibly the coracohumeral, but I'm not sure. This will be the proximal end. So yes, so that's a bit of the coracoacromial, the back of the coracoacromial, and this is probably the coracohumeral ligament there, would be my guess. But I wasn't really looking for that. I was just in shock that this patient turned up to me. And there,
hold it right there. Are you long axis on the coracoid right there?
Yep, and I'm moving it.
Oh, so my land! Wow. So it truly was just a non-union. It'd been too long. It's not going to sit there and regrow.
Nope, it's a fraction non-union of the.
So that's when you go in there with a needle and just absolutely chomp or hamburgerize that joint there and then hold it together. Really.
Not me. I send them off to a surgeon.
My land.
They turned up for an injection for impingement, and I said, no, you want to go and see a surgeon.
I need to have you get a hold of that SonoHack videoer, and I need to have you work on showing us coracoacromial and then coracohumeral, coracoacromial, so that I can refine my technique of pulling out that coracohumeral ligament when I'm scanning patients. because I'm sure you probably can get it 100% of the time. The last 3 shoulders, I've tried to find that sucker, and I said, "Oh man, my time is running up with the patient."
You can't see it you can't see it easily in normals. It's and there's a huge variation in how it is, which is what my surgeon friends say. The huge variation in how thick they are
Oh,
normally. Their position is slightly variable. Sometimes it's continuous with the pec minor tendon, and so you
interesting.
get quite a lot of difficulty. And even on sort of better scanners, it's a difficult view in a lot of shoulders. There just isn't the space there, isn't the soft tissue there, and it's pretty tricky to see. And it's a very awkward angle with the probe. So I wouldn't be in the slightest disheartened that you're not getting it, particularly where it's not thickened.
Well, but it because of its seeming uh, um, existence with a frozen shoulder, it is something that at least seems to be one of the things people say, and it was an enlarged coracohumeral ligament. And I'm going, well, I would like to at least be able to master this so that I could nail it 50% of the time. But what I'm hearing you say is 75% of the time on normal shoulders, it's difficult to isolate.
Yeah, it's a lot harder on a normal shoulder. In a good 50-60% of frozen shoulders, with a fair wind, you will see it. And I scan it routinely now to see if I can see whether it's and I'll see one most days, which is why I'm quickly looking to see if I can see it. I know I often take a little clip of it, but it isn't. It's just not always there, not always visible. I had a case of frozen shoulder yesterday or the day before where the patient was absolutely a frozen shoulder, and I could not. The coracohumeral ligament did not look abnormal in any way, and he was one of those ones with sort of mid range. He wasn't very tight, but he was restricted, side to side, diabetic, the right sort of age. And no other pathology, and so I don't normally lie them down and look in the axilla because it's uncomfortable position. It's not normally necessary clinically, but in him, I wanted to get some sort. I wanted to be able to nail it, and then I scanned the. Where is it? I've got the pictures somewhere. If you give me a moment, let's say winter 20th October. That's mild frozen shoulder. Yeah. So these were the pictures. So if we go, this is there's his capsule in shoulder on his lying on his side, scanning down the. This is the humeral head from the axilla. This is the capsule, and then and it isn't very thick. This was a slim guy with slim structures. That should can be up to 20, up to 50. But when you scan the other side, you can see quite clearly the difference. Capsule there, and then capsule there.
Wow, John, I think I've probably put the probe on one person's armpit and what you call axilla or something like that.
It's quite difficult, which is why I don't do it very often. I much prefer to see the coracohumeral ligament.
Right. But again, what did you do? Did you put a quart of hydrodissection in the what did you do for this guy? Did you just say go to therapy?
This was not somewhere where I was making the decision. So this was doing the scan for someone else, and so I just bat it back to them and say, depending on how the patient was doing, from my vague memory of it, the patient wasn't terribly painful, and so I would say if he's getting towards the end of that freezing period, the first stage, I'm often tell them, just sit it out. If it's starting to settle, it'll get better, and you just crack on. Avoid the physiotherapy often to let them settle down properly.
Yeah.
I don't recommend any sort of physio until they are pretty much pain free, and then I don't get them to push the stretching hard, because I think it has the potential to cause accessory movements. If you have something with particularly if there's something like a tight coracohumeral ligament, then that's like having part of your mast particularly tightly wound on one side. If you then go and shove it around, you're going to get accessory movement of I hear you. At the joint line, and I think that probably has some negative effects. Probably accelerates arthritis. So when people are stiff like that, I tend not to throw them at physio and get people to stretch a lot.
Well, I just lost $1,000 on you. I wonder whether you should move here now. No, I understand exactly what you're talking about. I'm going to let you go because I want your wife to like me, and we'll connect again in a week. And hopefully, what was I wanting to say? So I want to save fractures to the side, save coracohumeral ligaments to the side, and we'll go over technique on how you refine that if that works out, and if not, we'll just talk about what comes up. John, thank you for your time.
I'll see you later.
Talk to you later.
Cheers. Bye-bye.
Bye.